I don't think that my humor is necessarily dry. I just think it may be suffering from psoriasis. You ever wondered what you call a Native American who has psoriasis? Apache Indian. Hello everybody, it's Ryan here. Hope you and your family are well. Thanks for joining me in today's video. We're tackling quite a dry topic today, psoriasis. We're going to be covering a clinical case to give us some context into the condition. Then we're going to be breaking down psoriasis, an introduction followed by etiology, how patients present in terms of signs and symptoms, covering a plausible differential diagnosis, diagnostic evaluation, treatment and management options, prognosis and complications, and of course sharing from the Word of God. Thank you for joining me, and I hope all is well with you. So we got a 63-year-old woman today. She has a 5-year history of psoriasis involving her elbows that has been controlled with topical glucocorticoids and a vitamin D analog. Excuse me. However, in the past 9 to 12 months, her psoriasis has worsened and she has developed new lesions involving her knees, gluteal regions, and the scalp. She is increasingly uncomfortable and has noted swelling of her digits with pain and stiffness. Not a good sign, that. She is up to date on all cancer screening and has no sign of systemic infection. Her physical exam is only notable for psoriatic plaques that are red and scaling and swollen, tender DIP joints in both hands. All of the following therapies are indicated for worsening widespread systemic psoriasis except for, is it A, alefacept, B, cyclosporin, C, infliximab, D, methotrexate, or E, prednisone. Let's dig in, guys. Psoriasis. Now, psoriasis is a chronic inflammatory disease of the skin characterized by erythematous plaques often covered by a silvery white scale. That's the maxim for psoriasis. Erythematous plaques on a silvery white scale. It affects nearly 5 million persons in the States, which accounts for about almost 1 to 2% of the entire population. So quite significant. Peak of onset is 25 to 40 years for most forms of psoriasis. However, it can occur at any age, including in infants and among the elderly. Excuse me. Now, up to 25% of affected persons will develop psoriatic arthritis, which can result in permanent joint disability if you leave it untreated. So always be on the lookout for that. Now, psoriasis can have significant psychosocial and physical impacts. About 350 deaths occur annually due to psoriasis and its treatments. Now, guys, this video is going to cover psoriasis, the skin disease. We're not going to be looking at psoriatic arthropathy, which is a separate entity in a separate video. Here's some beautiful images taken from the Cleveland Clinic. Right, so this is psoriasis affecting the scalp. Here's psoriasis affecting the extensor surfaces, especially the forearms, the elbows. Here you have psoriasis affecting the dorsum of the hand. Let's talk etiology, epidemiology, and risk factors. So psoriasis is primarily a T lymphocyte, which is a Th1 or T helper 1 mediated autoimmune disease. It is associated with epidermal hyperproliferation, in that psoriatic epithelial cells have a cell cycle 1/10 as long as normal cells, and they take just 1 to 2 days excuse me, to migrate to the skin surface, as opposed to nearly 30 days in the normal skin cells. So they take a shorter time to migrate to the skin surface from the deeper layers in order to be exfoliated. Now, cytokines play a large role in epidermal proliferation, differentiation, and inflammation. Etiology is thought of to be multifactorial, has not been completely elucidated yet. However, a genetic predisposition is involved in that up to 75% of patients do have a positive family history. Now, the most consistent involved gene is the beloved HLCW6, which confers a 10 times greater risk, and yes, psoriatic arthritis is associated with its other brothers in the HLA-B27 genotype. Right? There are several different types of psoriasis, several different flavors. Plaque psoriasis, which is the most common, is also termed psoriasis vulgaris, accounts for upwards of 80% of cases. Then we also get the guttate psoriasis, sorry, more common in kids, may be triggered by strep infection. The pustular psoriasis may evolve from long-standing plaque psoriasis, may be triggered by tapering doses of systemic steroids. Exacerbating factors include trauma. Now, whenever we have psoriasis or any skin disease occurring at areas of trauma, we can refer to this as Kubnerization or Kubner's phenomenon. We're going to look at a picture Of course, other exacerbants include cold or dry climates, stress, smoking, HIV, pregnancy, medications, especially steroid withdrawal, lithium, hydroxychloroquine, non-steroidal anti-inflammatories, beta blockers, calcium channel blockers, terbinafine, which is an antifungal preparation, right? So psoriasis fits into the family of our papillosquamous disorders, right? And so that's here. And there's a beautiful table here from Harrison's, just contrasting the different papillosquamous disorders. So we're looking at them in terms of clinical features, other notable features, and histology. So psoriasis is sharply demarcated erythematous plaques with a mica-like scale. Salmon pink on silvery scale, essentially, predominantly on the extensor. So elbows, knees, and scalp. Atypical forms may localize to the intertriginous areas, like the axilla, the gluteal region. Eruptive forms may be associated with infection, right? Especially behind the ear as well. Other notable features, it may be aggravated by certain drugs, infection, severe forms seen in association with HIV, right? Yeah, histologically speaking, what you have is acanthosis and vascular proliferation versus lichen planus, psoriasis, rosacea, and dermatophytosis, which are different entities, but they still fit into the same family of the papillosquamous disorders. Excuse me. So regarding patient presentation, in plaque psoriasis, what we're looking at is thin, or rather thick, scaling red plaques on the elbows, knees, lower back, gluteal cleft, scalp, palms, soles may be extensive. Gutted psoriasis resembles rain droplets. Many are small, red, scaling papules, predominantly on the trunk, arms, and legs, which is more common in kids. Inverse psoriasis speaks to red patches in the intertriginous areas, but does not scale like other types, interestingly. Erythrodermic psoriasis refers to generalized redness and scaling, may be the presenting sign or may evolve from plaque psoriasis. Then pustular psoriasis refers to innumerable tiny pinpoint sterile pustules on a red background, which may be localized or generalized, may arise from pre-existing plaques, or patients may be febrile with severe itch. Palmoplantar pustulosis refers to many pustules on a red base occurring on the palms and soles. Nail psoriasis is a specific entity speaking to pitted oil spots, distal onycholysis, right? So this is plaque psoriasis, which is typical psoriasis vulgaris, which we see on the dorsum of the hand in this instance. This is guttate psoriasis, looks like it's erythematous and looks like tiny droplets of rain, right? And that occurs mostly in kids. Then we've got the inverse psoriasis. Here we just have an area. It's a patch of erythema, right, where there's no scaling, okay? And that occurs in the flexures as opposed to the extensors. Remember, psoriasis loves the extensors. This is erythrodermic psoriasis on the back. Pustular psoriasis, excuse me. So these are basically, sterile lesions, okay, not infected. These are the variety of changes in the nails that we have in psoriasis. So this is a normal nail. With respect to pitting in the nail, which is shown here, these tiny little depressions or pits in the nail. Onycholysis, which refers to destruction of the nail. Subungual hyperkeratosis we see here happening at the base of the nail. We have ridging, kind of like striations, right, orientated vertically. We have nail thickening, we have nail crumbling, and color changes as well. Okay, this is just a demonstration of Kubner's phenomenology, which happens at areas of trauma. So any skin manifestation which occurs at an area of trauma is something we call Kubnerization, right? Differential diagnosis for psoriasis is a whole lot, guys. But remember that psoriasis loves the extensors, right? Eczema loves the flexures. So eczema, tinea infection, sebderm, lichen planus, psoriasis, rubra pilaris, psoriasis rosacea, onychomycosis, which is fungal infections, right? Cutaneous T-cell lymphoma, Sézary syndrome, right? Cutaneous lupus, dermatomyositis, viral exanthem, secondary syphilis, folliculitis, and drug reactions. All of them can mimic psoriasis, guys. How do patients present? So in history and physical exam, you need to note when the symptoms started, so the time course of the onset, family history, new or changing medications which may have exacerbated the current presentation, morning stiffness in the joints, speaking to psoriatic arthropathy, which is an inflammatory arthropathy, arthralgias or arthritis, and any preceding illness. Once you evaluate the presentation and distribution of the lesions, nail and scalp changes can be a clue to the diagnosis, so always look in these areas. Removal of scale produces pinpoint bleeding, something we call the Auschwitz sign. Skin biopsy is a gold standard for diagnosis. Potassium hydroxide tests and fungal cultures may be indicated to distinguish psoriasis from fungal infection, right? So here we have other papillosquamous disorders. Remember we said that psoriasis fits into the family of papillosquamous disorders. So lichen planus, an example of lichen planus here showing multiple flat top violaceous papules and plaques. Let's talk about the P's, polygonal, purplish, papules, and plaques. That's lichen planus. Nail dystrophy as seen in the patient's thumbnail may also be a feature. Here we see pityriasis rosacea. In this patient with pityriasis rosacea, multiple round to oval erythematous patches with fine central scale are distributed along the skin tension lines on the trunk. Okay, there we go. These are once again the different types of psoriasis in a nutshell. So plaque psoriasis is typically on the dorsum of the hand here. This is guttate psoriasis looking like a whole lot of raindrops. Pustular psoriasis, which are sterile pustular lesions. This is psoriasis in the hairline and the scalp. Psoriasis affecting the nail and psoriatic erythroderma. Okay. Guys, how are we going to evaluate these patients diagnostically? So we already spoke about a couple of investigations. Other testing is based on ruling out other disorders in the diff diagnosis. You want to assess for folliculitis in suspected cases of pustular psoriasis, and assess for other forms of erythroderma in suspected cases of erythrodermic variant of psoriasis, including a thorough examination for other inflammatory dermatoses, lymphadenopathy, changes in the palms and soles, and nail changes, along with the full blood count with the Cesare count and chest X-ray. That happens in cutaneous T-cell lymphoma, right? The Cesare syndrome. There is no diagnostic test for psoriatic arthritis. Joint X-ray may show so-called pencil and cup deformity of the digits. Most affected joints have no X-ray findings, but we will talk about psoriatic arthritis in a separate video, all right? Regarding treatment and management, guys, treatment is based on the type, the extent, the distribution, and severity. The type and extent, distribution, and severity of disease. You must weigh individual risk to benefit ratio when you are choosing, especially systemic treatments. A limited disease of the hands and feet can be very disabling and may warrant more aggressive treatment despite the small surface area involved. So don't be fooled by the relatively small surface area involved in just hand and foot disease. It can be quite debilitating, right? Topical therapies include medium to high potency steroids, calcipotriene, tazarotene, which is retinoid, tar or anthraline preparations. For thick plaques, salicylic acid and urea preparations may help to reduce the scale. Scalp lesions can be treated with topical steroid shampoos, solutions, or oral preps, along with tar, anthraline, or salicylic acid shampoos. Laser treatment can be used for stable recalcitrant plaques, right? Phototherapy may be used for more generalized disease like ultraviolet, UVB, or PUVA, which is Sutherland plus UVA, given 3 times a week, right? Phototherapy may be used for more generalized disease. We talk about UVB and narrowband UVB or PUVA. You may want to combine with the oral retinoid, tar, or calcipotriene for increased efficacy. Systemic treatments as well include acitretin, which is oral retinoid, methotrexate, cyclosporin. TNF-alpha inhibitors, the likes of infliximab, etanercept, adalimumab, are now FDA approved for psoriasis and for psoriatic arthritis. Other biological agents include efalimumab and elefacep. Antibiotics may be indicated in cases of guttate psoriasis following strep infection. Guttate psoriasis responds very well to ultraviolet therapy. Patients with psoriatic arthritis should be referred to a rheumatologist, okay? So these are just looking at some FDA-approved systemic therapy for psoriasis, right? So methotrexate, retinoid, cyclosporin, apremilast. Very important when using methotrexate, it's a weekly oral dose that we administer, right? And you got to watch out for adverse events being hepatotoxicity, pulmonary toxicity, right? It has been linked with interstitial lung disease. Pancytopenia, the potential for increased malignancies, arthritis, stomatitis, nausea, diarrhea, and teratogenicity. So if the patient is planning on getting pregnant, do not start methotrexate. Do not start retinoid systemically. All right. Cyclosporin is known for renal dysfunction, hypertension, hyperkalemia, hyperuricemia, hypomagnesemia, hyperlipidemia, increased risk of malignancy, right? Phosphodiesterase type 4 inhibitor systemically is apremilast, which you give twice daily orally. This is just looking at the FDA-approved biological treatment for psoriasis or psoriatic arthritis. So your anti-TNFs, the famous etanercept, adalimumab, satralizumab, pegol, infliximab, golimumab, and then you've got the anti-IL-12 and IL-23, ustekinumab, anti-IL-23 in the way of these drugs, and anti-IL-17, the most famous, secukinumab. Right? Watch out for serious infections in all these biologicals. Okay, guys, remember the clinical course of psoriasis is somewhat unpredictable. It tends to wax and wane over the lifetime. It may persist in a localized form or progress to more extensive involvement. Gutted psoriasis, which happens in kids, may remit completely or may develop into plaque psoriasis. Arthritis may result in permanent joint deformity, quite debilitating. Erythrodermic and generalized pustular forms often require hospitalization, and they may complicate with dehydration, electrolyte abnormalities, hypocardiac failure, acute respiratory distress syndrome, and hepatitis, which have been reported in some cases. Complications from treatment are legion, and these include skin atrophy, stria, telangiectasia due to the topical steroids and thinning of the skin, increased risk of skin cancers, especially with PUVA therapy, cytopenias, hepatitis, psoriasis, nephrotoxicity, opportunistic infections, hypertriglyceridemia, especially on the back of retinoid therapy. Guys, coming back to our clinical case, right, we had an elderly female who comes to you, 5-year history of psoriasis on topical glucocorticoids and vitamin D analogs. However, recently her psoriasis has worsened. She has new lesions involving these areas. She's very uncomfortable. She has noticed swelling of her digits with pain and stiffness, probably psoriatic arthropathy setting in. She is up to date with all cancer screening, no signs of systemic infection. Physical exam is notable for psoriatic plaques that are red and scaling and swollen, tender DIPs on both hands. Which therapy is indicated for worsening widespread systemic psoriatic disease? The answer is prednisone, guys. All patients with psoriasis should be advised to avoid excessive drying of the skin and to maintain hydration. Secondly, bacterial infection should be suspected with local worsening and treated appropriately. Oral glucocorticoids should not be used for the treatment of psoriasis due to the potential for developing life-threatening pustular psoriasis when the treatment is removed. So going back to that, the other options are acceptable, but prednisone is the one that's not recommended in this scenario because of the risk of life-threatening pustular psoriasis. Okay, my friends, I just want to talk a bit about Scripture. Right, we're talking about loving the Lord and loving our neighbors, right? You know, one of the scribes, one of the Pharisees asked Jesus, which is the greatest commandment? And Jesus replied with Matthew 22:37-40, which is what is recorded for us in terms of Jesus' response. He said, love the Lord your God with all your heart, with all your soul, and with all your mind. This is the first and greatest commandment, and the second is just like it. Love your neighbor as yourself. All the law and prophets hang on these two commandments. So the greatest commandment is like a coin, because a coin has two sides. On one side, love the Lord your God with all your heart, with all your soul, all your mind. On the other side, love your neighbor as yourself. So love for God and love for people. So if you think about the cross, love for God represents the vertical portion of the cross, and the horizontal portion is love for our neighbors, love for people around us, not just our own family members, but love for people in general. I pray that'll be the desire for our hearts to show love in everything, both to God and to people around us. These are my references, everybody. You can catch me on Facebook. Just search for Algorithms and Mnemonics in Internal Medicine. You can also find me on TikTok and on Instagram as well. God bless you. Thanks for joining me. We're going to be talking about amyloidosis in the next video, God willing. Have yourself a lovely day, and I'll see you soon.